This is Breakthroughs, a podcast from Northwestern University Feinberg School of Medicine. I'm Erin Spain, Communications Director at Feinberg. The journey to becoming a surgeon is long and demanding, but for women who want to break into this male-dominated field, it's even tougher. In a recent Northwestern Medicine study published in the New England Journal of Medicine, female surgical residents reported more mistreatment than men, which was linked to higher burnout rates and more suicidal thoughts. Today, I'm joined by the study's corresponding author, Dr. Karl Bilimoria, director of the Surgical Outcomes and Quality Improvement Center at Northwestern, and I'm also joined by the study's first author, Dr. Yue-Yung, a surgeon at the Ann and Robert H. Lurie Children's Hospital of Chicago, and also a member on the Surgical Outcomes Quality Improvement Center team. Thank you so much for being here today.
Thank you.
Thanks for having us.
So you're both surgeons, and I'd love to start off this conversation by talking a little bit about why did you choose to become a surgeon?
Well, for me, the path has been known for a long time. So I was in fifth grade and had a family member pass away from a cancer and had a sister who was having a lot of surgeries. And so the idea of coupling what I saw in surgery with the idea of taking out tumors was something that resonated with me. I didn't know surgical oncology was a thing at that point, but that's where I drove my focus since about fifth grade.
And how about you, Dr. Who?
I was sort of the opposite, actually. I thought I was going to go into primary care pediatrics. And then when I rotated on surgery and primary care pediatrics, I was sort of surprised to find out what I enjoyed. But I liked the thought process of surgery. I liked the colleagues in surgery.
You know, the latest statistics show only about 20% of American surgeons are women, and that is kind of telling about the culture of surgery a little bit. There hasn't been many women traditionally going into the field, but that's changing. Isn't that right, Dr. Who?
That's right. So about 20% of practicing surgeons are women. But in residency, currently about 40% of the population is female. And we're seeing applications come in that are closer to 50-50.
So this is a big shift compared to decades past. Is that right, Dr. Bilimoria?
It is a big shift, and it's hopefully a sign that we're evolving as a field, but maybe not as fast as we'd like to, based on some of our recent evidence.
Well, right. Let's talk a little bit about this study that we're talking about today in the New England Journal of Medicine. It's sort of a continuation of the first trial. Just to give me a little background about that trial. You've published many papers really looking at the residents, male and female general surgery residents, their duty hours, burnout, mental health. What have you found in the past?
Well, the first trial was designed to look at how we can train residents differently, and it was focused more on duty hour policies. But as a byproduct of that, one thing we wanted to study was to be sure that their well-being didn't get worse if we trained them in a different way. And what we saw was not a difference between the two study arms, but rather that both groups, both study arms, had declining well-being over the 4 years that we were watching their well-being and burnout. And so that led us to really dive deeper into the topic, ask more questions in the annual survey that we do of the residents across the country, and learn more about burnout and understand far more. We also conducted a number of interviews over the years with residents across the country to better understand why we were seeing this decline in well-being. And that's really where we got the motivation for the current work.
And so it was after that first paper was published, Dr. Who, you started to notice a trend with women, female residents. What were some of those trends that were coming out?
So we found that there was a higher rate of burnout in women, which replicates prior research about women in medicine in general. And we wanted to know why. I think there has been some question about whether it's something about women that makes them respond differently to the same amount of stress, or is there something different in the environment for women? So we did some qualitative work, as Karl had mentioned, around this, and women were describing differential treatment. So on the 2018 ABSITE survey, we asked about gender discrimination, sexual harassment, and discrimination related to pregnancy and childcare needs. We also asked questions related to mistreatment that were not gender related, so racial and ethnic discrimination and verbal and physical abuse. The survey is attached to the American Board of Surgery and Training examination. That's a test that every surgical resident in the country takes every year at the same time. And that is largely how we're able to achieve such a high response rate.
You had like 99% respond to your survey.
Yeah, so it was, sort of an unprecedented response rate. So we got a really good picture of what was going on. And so we think this is one of the best estimates of burnout in the medical population to date.
This new paper, which is published in the New England Journal of Medicine, explains what really may be causing this higher rate of burnout in female residents. Tell me about these findings. They're pretty interesting. Dr. Bilimoria, could you start?
We saw initially what appeared that women were experiencing more burnout than men, and more thoughts of suicide than men. But once we adjusted in the models for these mistreatments, the harassment, discrimination, and verbal and physical abuse, we saw that there was no longer a difference between men and women in terms of burnout and suicidal thoughts. And so this turns out to be one of the major drivers. And it's not that we can just eliminate this, but if we're going to focus our efforts, this should be an area where we really may be able to help women in the field of surgery if we can work toward reducing the frequency of mistreatment.
So when we talk about mistreatment and discrimination, Doctor, who is this coming from? How are these residents experiencing this? Is it from patients, families, fellow surgeons?
All of the above.
Okay.
So for gender discrimination, about half of it was from patients and families. For sexual harassment, it's a mix of patients and families, attending surgeons. And a little bit less from co-residents. So it just depends on the particular type of mistreatment. We are currently working on 2019 data, in which we ask the specific behaviors that people are experiencing. So, for example, discrimination that manifests as differential evaluations comes from attendings, but being mistaken for a non-physician comes from patients and staff.
So that's something like they think they are a nurse or maybe they are not the surgeon.
Exactly.
Okay. And there's also been data out there that patients are more likely to call a female surgeon by her first name and call a male surgeon doctor. So that persists, and that does have an impact.
That also happens with faculty, even. There's data showing that at meetings, women are more likely to be introduced by their first name and men are more likely to be introduced by their title.
So, these long hours, split-second decisions, emotionally charged environments, burnout is a common topic across medicine. And maybe we should define a little bit, what are those symptoms of burnout when we talk about burnout? What does that look like?
So when we measure burnout, we use the Maslach Burnout Inventory. It categorizes burnout into three subscales. So there is depersonalization, which is losing empathy for the patient, essentially. There's emotional exhaustion, and there's personal accomplishment. We find that there's not a lot of variation between surgeons and probably really physicians in general in terms of personal accomplishment. They're pretty accomplished individuals, and so it's really the first two that are important.
How does that affect quality of care for patients when your surgeon or doctor is feeling this way? Does it translate into how they are treating patients?
There's a lot of data published in this field, actually, by others, showing that physicians who report more burnout, they also report more medical errors. They're more likely to leave their jobs. They're more likely to leave the field of medicine. So there are significant impacts for both patients and the whole field of medicine.
You have published, as we said, other papers sort of leading up to this finding. But what's been the response from peers in your community who've had the opportunity to see these results?
The field has become very accepting of this issue. And very progressive on this issue, to be honest. The old school attitude of burnout isn't a problem, and that we define ourselves by how long we work and how hard we work has started to fade, with a nice balance of understanding our commitment to the patient coming first and foremost, but also that our well-being is needed in order to care for the patients. And so I think that this balance is really well recognized. And to be honest, the leaders in the field of surgery have stood up and taken a stand that this is an issue. And if anyone could have blown it off, it could have been them. But they've really shown us that they understand this problem and want to work toward meaningful solutions while maintaining excellent patient care and excellent resident training.
Something important to note about the study is that some medical centers are doing an awesome job at preventing burnout or how they work with surgeons who may report it, and other centers are not doing well at all. Dr. Hu, could you talk a little bit about those ranges and what you saw in the survey?
Yeah, sure. Part of what we do when we analyze the ABSITE survey is we look at the variability and all these different metrics between different programs. So we have found that there's wide variation in discrimination rates, even different types of discrimination rates, and also in burnout rates. So I think there's things to learn from each one. So part of our ongoing work currently is to visit a lot of these places and figure out exactly what they do. So we visit places that are really great at avoiding discrimination. We visit places with really low burnout rates, et cetera.
One thing that was striking to me and may not be striking to some of the female surgeons was where the sources of the mistreatment was coming from. And that's really important to understand. We talked a little bit about it, but I was struck by the fact that a lot of the discrimination came from patients and families. And that you have to really focus in on, because if you're going to intervene and say retrain all the faculty and retrain all the people in the hospital about how not to engage in that kind of behavior, that's not going to be effective, because we have to talk about the patients and families, and you can't change society. So our interventions, if we're going to seek to improve on this, really need to consider the source data.
And when you talk about interventions, is it something sort of like a zero tolerance policy for that type of behavior? What are some of the reactions that can be put in place at these hospitals?
It may be policies and procedures. It may be training. It may be leadership attitudes. It could be in any number of things. But if you could imagine that, the residents who are experiencing the discrimination need to be well prepared for how to handle it and how to push back against patients in a thoughtful and kind way that allows them and empowers them to continue to care for the patient. And it's not only the residents, also the bystanders. So if a medical student the male medical student is being spoken to instead of the female chief resident, it should not only be on that female chief resident to redirect the patient, right? So the medical student needs to feel like they have the speech and are empowered to help redirect that conversation. And so you can think about the intervention being training of different types.
17% of surgery residents also reported racial discrimination. This is a new finding?
It is a new finding, and it's probably an underestimate because we didn't account for race. So once you take into account the percent of surgical residents who are not white, that number is probably much higher.
So will this be a future area of research now that it's been identified and there's more questions that can be asked now?
Yes, exactly. So it is something we asked about on the last survey.
Great.
And something we'll continue to look into.
Well, yeah, so you're talking about the next survey, and there's actually going to be sort of a part 2 to this trial called the second trial. Dr. Bilimoria, tell me about that new trial and where we are with it and how you're going to be able to build on what you've done in the past.
Yeah, so we had a first trial, so of course we have to have a second trial, and so that's an acronym for the trial name. But the second trial is going to look at how we can improve the learning environment for residents. And specifically, we're going to take what we do in quality improvement approaches and apply that to this problem. And so we're going to be providing programs, residency programs, with their data. So they'll actually get to see how they perform on burnout and how they perform on the proportion of suicidal thoughts and autonomy and other things that really drive resident well-being. And then they'll be able to identify targeted areas on that report where they need to improve. So they'll see that they have the worst burnout, let's say, in the country. And then they'll be able to act on that. And then we're giving them tools to improve. So we are, from all the site visits the team is doing, from the literature, from best practice guidelines, from interviews with leaders in the field, we are identifying a series of best practices and interventions and putting them into a catalog, a toolkit, where if you identify a specific area of weakness, let's say you have a high rate of sexual harassment, you can go to the toolkit and identify what other programs have done to have good performance in that area and to intervene on that. It may be training, policies, protocols, all sorts of things. And hopefully they're ready to use interventions. These people are going to provide what they do and put into the toolkit ready to use interventions.
Where are you at right now then with the second study? Where are you at in the process of the research?
So we're almost closing the enrollment for the second trial. So we're at about 200 programs in the country that have enrolled. That makes it one of the largest trials certainly in surgical education and potentially in medical education. And so the trial will kick off within the next 6 weeks or so, and will run for a couple of years.
I'm sure that it's going to be pretty eye-opening to some of these institutions to see their own results.
Yeah, I'm one of the associate program directors in this program, and it is really hard to that's really hard to have that insight on your own program. Like unless you train here, you may not know exactly what people are exposed to. And if you're not a woman in the program or a minority or whatever, you may not know their experience. So this will be the first time anyone has this kind of data.
And how close will the two of you and other investigators on the trial be to explaining those results and really walking people through what they can do to change the outcomes?
As the coordinating center for the trial, we are planning on walking them through all the reports as well as how to use the toolkit and what to select. We also will be providing implementation support to help them put whatever protocol they choose to work on in place.
So we'll be connecting them. We'll be creating a learning network across the country. So if at Wisconsin they created a really innovative program to address a particular issue, we will find that leader from Wisconsin, have them do a coaching call with the rest of the country. They'll be the coach for anybody else who wants to do that. And there's tremendous value, right? You would want to know how they did it. What barriers did they find? How much did it cost? And so connecting the community in this way should lead to lots of learning.
So what's your hope? What do you hope 10 years from now, when you do this survey again, what do you hope you're going to see?
I would hope that this mistreatment would be pretty minimal. As you mentioned, a lot of places have zero tolerance policy. I would hope that would have an effect. I would hope that burnout rates would be on their way down.
Yeah, our hope from the trial is that we'll be able to show that giving programs their data and the tools to improve leads to really meaningful improvement across the country, and that the rates of burnout, thoughts of suicide go down considerably, and overall the learning environment improves and results in better surgeons.
Well, we look forward to hearing what's going to happen next year as you send out and start the second trial, and we'd love to have you back to talk about results then. So thank you so much, Dr. Karl Bilimoria, Dr. Hu, for coming and being guests on the podcast, and we look forward to seeing you soon.
Thanks. Thanks for having us.
Thank you.
A note to all of our listeners, did you know that Breakthroughs is CME credited? Go to our website, feinberg.northwestern.edu, search CME, and start taking some of the courses and claim your credit. I'm Erin Spain. Thanks for listening.